Hi, everyone. My name is Dr. Dapo Iluyomade, and I'll be introducing our speakers today for the Achieving Health Equity Moving from Observation to Implementation session at QCOR 2022. First, we have Dr. Amber Johnson.
I'm Amber Johnson. I'm from the University of Pittsburgh, and today I spoke about how workforce diversification can improve health equity outcomes. We have data to show that health equity and diversification are two separate entities that deserve funding and support from our institutions and from a national perspective. But we also know that despite these being two different entities, a lot of the times the folks who are doing health equity research tend to come from diverse backgrounds. That has implications for the work that's done, how the work gets done, how the work gets funded, as well as the promotion and tenure of the folks who are doing the work. We also know that people who are from diverse backgrounds have relationships with their communities, and they have empathy with their patients and better patient-reported outcomes. So we need to do better jobs of supporting those from diverse backgrounds that can help us to improve health equity outcomes.
Thank you, Dr. Johnson. Next, we'll hear from Dr. Tiffany Powell-Wiley.
Thank you so much. I'll be speaking about reducing biases in artificial intelligence and machine learning to achieve equitable outcomes in cardiovascular care. We know that the use of artificial intelligence can really revolutionize cardiovascular care, whether it be through the diagnosis and determining the prognosis for cardiovascular disease, but also the opportunities to improve efficiencies and incorporate new novel types of data into the care for our cardiovascular patients. Unfortunately, we know that there are numerous pitfalls in the use of artificial intelligence and machine learning. Much of the data that we use come from systems where populations that are at highest risk for disease may have difficulty with access to care, but also because of biases in clinical care, there are ultimately biases in the data that can be incorporated into machine learning algorithms. And so today I talked about a project that we are doing at NHLBI in collaboration with Howard University, as well as working with other institutes at NIH, including the NIH Clinical Center and the National Institute on Minority Health and Health Disparities called HopeNet. This project is a collaboration with Howard University to work with an existing community advisory board to look at how we can use novel data elements, particularly unstructured data from group-based model building with both clinical researchers, but also with community members to determine what are barriers to clinical trial participation among African Americans, but also what are predictors of those barriers and how we might be able to use machine learning to identify predictors of those barriers. Our hope is that this type of tool may help us in better defining what barriers to clinical trial participation for African Americans exist, but also we hope to develop a tool that can be utilized across clinical trials in improving recruitment of African Americans to studies. Thank you.
Thank you, Dr. Powell-Wiley. We'll be looking forward to the results of your research in the future. Next, we have Dr. Modele Ogunniyi.
My name is Dr. Ogunniyi. I am at Emory University in Atlanta, and today I talked about delivering equitable cardiovascular care, responding to patients' needs. We talked about the fact that it's important to address social determinants of health, and that 80% of cardiovascular outcomes and really health outcomes are driven by social determinants of health. I also shared practical strategies that we employ at Grady Health System in Atlanta to address social determinants of health. I talked about our Food as Medicine program that addresses food insecurity among our patients. And I also talked about the Grady Heart Failure program that has health equity core components that address social determinants of health. So the core equity components in our program include provision of a 30-day supply of medications to patients admitted with heart failure, providing financial assistance to those who need it, providing rideshare support, and connecting our patients to community resources through a dedicated community health worker. So I think that in order to achieve health equity for all patients, we really have to think outside the box and develop a multidisciplinary team that addresses 80% of what drives health outcomes, and that is social determinants of health. Thank you.
Thank you, Dr. Ogunniyi. Next, we have Dr. Rishi Wadera.
My name is Rishi Wadera, and I work at the Richard A. and Susan F. Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. And my talk today focused on the Affordable Care Act and cardiovascular health equity. The ACA, or Affordable Care Act, was one of the major health policy reforms to be rolled out over the last few decades. And it really had two core components or goals. One was to improve access to care by expanding the Medicaid program and private insurance exchanges. And the second goal was to improve the quality of care we deliver at lower cost through value-based policies. The evidence suggests that the Medicaid expansion under the ACA was a very successful policy, because we now know that Medicaid expansion has led to increases in primary and specialist care, increased identification and treatment of cardiovascular risk factors, and perhaps most importantly, a reduction in cardiovascular deaths. In contrast, value-based policies, which were rolled out with a lot of enthusiasm, have had more limited success and haven't quite generated the savings we hoped for, nor generated significant gains in terms of quality of care. So moving forward, as we think about the next decade of delivery reform, I think that we need to move towards a more empirical rather than aspirational approach to policymaking, and randomize evaluations of policies whenever we're able to, so that we understand whether they're going to work or not work before widespread implementation. Second, we probably need to move away from a carrot and stick approach to quality improvement, measurement, and attaching financial incentives to measurement, and try to tap into the professionalism of clinicians that will incentivize them to improve quality of care. And third, and probably the most importantly, we need to prioritize equity in all of our value-based policies, and recognize that although our healthcare system spends too much money, sometimes we do need to spend more money to meet vulnerable and marginalized communities' unmet needs.
Thank you, Dr. Wadera, for sharing those potential solutions to some very important problems that we face. Lastly, we'll hear from Dr. Harriette van Spall.
I was delighted to be here today to discuss diversity in cardiovascular clinical trials. We started off the session discussing how women are under-enrolled in clinical trials relative to disease distribution across cardiovascular conditions and in landmark clinical trials that have shaped cardiovascular care. Women are under-enrolled, and this has not changed over the last 20 years. I presented some of our work showing that sex-specific eligibility criteria, trial leadership by men-only authors, and ambulatory recruitment are independently associated with the under-enrollment of women in cardiovascular clinical trials. We also looked at the representation of Black, Indigenous, and people of color in our clinical trials and found that these groups were also underrepresented relative to disease prevalence. And two large analyses demonstrating that women clinical trial leaders are somehow more effective at enrolling both women and Black, Indigenous, and people of color in cardiovascular trials. We also looked at geographic inequities in clinical trial enrollment, and we found that vast areas of the world where people are living with disease are excluded from clinical trials, both in terms of clinical trial leadership and participation, and that clinical trial recruitment paralleled clinical trial leadership, and that clinical trial leaders who were in centers in these underrepresented regions had a 10 times greater odds of enrolling people in these regions that are currently underrepresented. So part of the strategy to increase representativeness in clinical trials, which increases the external validity, allows statistical power to test for subgroup interactions, expands the benefits of trial enrollment to underrepresented groups and historically marginalized groups, is to diversify clinical trial leadership. Other factors that we might control: how we design eligibility criteria. More pragmatic criteria facilitate greater representativeness, using patient-centered design, language that is inclusive, consent processes, trial follow-up processes that are remote and don't rely on patients to come to our centers for follow-up, and other patient-centered ways of engaging communities. Community-based participatory research may be a way of engaging diverse community members in the cardiovascular clinical trial enterprise. These are highlights of what I discussed at our session today, and I'm grateful for the opportunity to be here.
We'd like to thank all our panelists and my co-moderator, Dr. Adedapo Iluyomade, for a thought-provoking health equity discussion, and we hope that you all will be champions for health equity. Thank you.